where our mission is to eliminate racism and empower women. Tonight, we will continue our work of listening and reflecting as we delve into this deeply necessary conversation. A special thanks to the National Coalition of 100 Black Women Harrisburg, as well as the Sigma Gamma Rho sorority graduate chapter located in central Pennsylvania, for collaborating with us on this evening's Community Now. We have four wonderful panelists with different backgrounds and perspectives who have very generously agreed to share their expertise with us and help us to reflect. Thank you. First, we have Heather Doyle. Heather is, is a Master's of Public Health candidate with a wealth of experience in HIV and infectious disease. Her passion for learning about HIV specifically its effects on women of color predates her professional career. She is a former medical case manager with Alder Health Services, and currently she is an infectious disease program specialist with the Pennsylvania Department of Health Bureau of Epidemiology. Venus Ricks is an equity training and strategy specialist with the Center for Race and Gender Equity at YWCA Lancaster. She has spent over 15 years working with groups and organizations in creating more diverse, inclusive, and equitable spaces. Her experience crosses both the higher education and community sectors. As an equity training and strategy specialist, she uses a socialization to liberation model in working to dismantle systems of oppression and create equitable spaces for marginalized groups to thrive in their home communities and work environments. Jillian Sumter has seen firsthand what HIV can do to urban communities. Working in support services with HIV patients in large hospital systems, Jillian uses her role in the workforce as an example that you can work full-time and still pursue entrepreneurial avenues simultaneously. With an educational background in the healthcare field and 10 years of service working with the HIV and drug and alcohol rehabilitation programs, Sumter advocates a lifestyle of self-worth, high self-esteem, and self-love. Finally, we have Sandra Valdez. Sandra has been employed with SACA, the Spanish American Civic Association, for over 21 years, where she has amassed a wealth of experience. With more than 20 years of experience in the HIV/AIDS field, she oversees SACA's HIV department. Her active commitment to community is evident. She volunteers with SACA's food insecurity efforts. She's the co-chair of the Lancaster County Campaign Against Sexual Exploitation of Children. She's a board member of the Ryan White 340B National Coalition, Leadership Lancaster, Communities That Care, Crime Prevention Task Force of Lancaster County, Lancaster General Health Community Advisory Board, and the Pennsylvania Disproportionate Minority Contact Youth Law Enforcement Coalition. After those amazing introductions, I don't want to waste any time. So let's just jump right in and we'll go ahead and get started. As we proceed, you are invited to ask questions or share comments using the chat functions. My colleagues, Jasmine King and Adam Hosey, are skillfully managing these systems, and we will have time for some of these questions later. So let's begin. What's happening now? So to get started, Venus, if you could give us some background, like what is it that we need to know when we begin to think about Black and Brown populations and HIV?
Well, I will first start and say of the experts in the crew. What I came to this topic was one, through my membership in my sorority, so Sigma Gamma Rho Sorority Incorporated, Kappa Omicron Sigma. And we have our A3 programming. And I also, as I said earlier to the group, noticed that numbers in our area were quite staggering for Black and Brown women. And so I thought to myself, why aren't we talking about it? So I just started looking up things, and part of my job is to create community information, to create knowledge, to create opportunity to discuss difficult things. And so I said, why not do one of these? And so here's what I learned as I was getting prepared for this. So those of you who are not statistics people, just bear with me for a little bit, because I think it's important to know numbers as well as know experience of people, right? So I do have national numbers, but I'm going to kind of stick to Pennsylvania and our region here, which when I say region, I mean York County, Lancaster County, and Dauphin County. So in the state of Pennsylvania, Black and African Americans make up 11% of the state. Latinx folks make up 6.6% of the state. And of those numbers, 47% are new cases of HIV and 18% are new cases. So of the 11% of African Americans and Black people, there's 40% that are new cases and 18% of Latinx folks numbers, right? And these numbers are between the ages of 20 and 49. Also, Blacks and African Americans account for over 49% of cases in Pennsylvania. And of this, African American females make up 59% of that. So there you can see that there are disproportionate numbers. And I just kind of want to share that picture. I just will share lastly, before I leave it to, like I said, the real people who are actually out there doing the work from day to day. Main modes of transmission for Dauphin, Lancaster, and York counties: males having sex with males, IV drug use, and females having sex with males. And at the end of 2018, which I think might be the most recent numbers, 29% of the cases in Pennsylvania were in Dauphin County, 23% were in Lancaster County, and 21% in Dauphin County. Dauphin County actually is after Philadelphia in numbers. So just something for you to ponder and think about.
Thank you so much, Miss. So now that we have a frame set up for where we are heading with this conversation, Heather, I would like to come to you. And so can you talk with us a little bit about what are the current risk factors for African-American women in contracting HIV?
Yeah, so this will kind of follow up with what Venus spoke about, but just more on a macro level. Since she kind of covered Pennsylvania and our region, I'll kind of cover what we're looking at from a national level. Gaps in care are really what we're facing as far as risk factors. Specifically, African-American women, if they are diagnosed within maybe a year or so of them contracting HIV, they normally get diagnosed and then they won't follow up. So they won't follow up with their primary care physician. They'll just continue to get like medication renewals. They won't actually fulfill their entire treatment plan as far as taking care of their HIV. That's one of the main risk factors is I'm diagnosed and now I just kind of drop off as far as taking care of myself. The second biggest one is African-American women who, like Venus said, one of the largest numbers of individuals who contract HIV are African-American men who sleep with men. And what's happening more specifically within the past 5 years is the rate is going up for the age group of 24 to 35 for African-American women contracting HIV. It's actually 92% of all new cases for African-American women. HIV is contracted through heterosexual intercourse with men. So what that shows us is men are having sex with men, either unprotected and not sharing their status with one another, and then they're bringing it back home to their wives and their girlfriends. And those female partners are unsuspecting of that. So then they may go on about their life, not ever getting an HIV test, not going to regular care, as a lot of our community, we don't actually go to the doctor in the hospital and get checked up on as much as we can. So that is like the second risk factor is women who are contracting HIV from having sexual intercourse with men who are sleeping with men. And then the third would actually just be health equity as far as their access to care. If women are actually getting tested regularly and getting diagnosed, whether it's early detection or not, when they get care, there's an overall stigma. They may have that cultural imbalance where they may feel slighted when they're at the doctor. They may not follow up with their infectious disease provider due to a bad or a negative experience. So I would have to say, just from the trends that I see, those are the ones that really, really put African American women at risk. You can interchange them sometimes depending on the region you're looking at or the state you're looking at, but just from a national level, that is really what's happening. Women are having sex with men who are having sex with men. They are not following up with care. And then when they do follow up with care, they're not being treated properly by physicians and providers, which makes them not want to return for proper care.
Okay, thank you very much. Sandra, could you follow up with sort of the same question, but speak to us about it from the Latino population?
Yeah, so I'm really going to piggyback on what both ladies have mentioned thus far. But in regards to the Latino population and statistics, currently, specifically in the Lancaster County, I'm going to bring it down to Lancaster, of course, because I'm from the Lancaster area, is that 19% of the risk factors are between individuals who are intravenous drug using, and 63% or more are heterosexual. And it alludes again to what Heather was kind of mentioning, you know, the trend of, yes, in the Latino population, as African American, men who have sex with men tend to be the higher at risk, though they're taking risk or being sexually active with females who are basically being put at risk as well. So in the statistics, even though the Latinos make up 27% of all the new diagnosed cases as of you know, the CDC statistics as of December 2018, we continue to put ourselves at risk. Currently, across Latinos tend to be steady of the increase of infection, though it is increasing among men who have sex with men. And kind of what Heather mentioned, you know, it also in the Latino population comes back to healthcare and why women tend to take care more of their loved ones, their family, before they take care of themselves. So that, you know, definitely is presidency among the Latina women when they have children, when they have husband, when they have family, you know, they tend to take care of everyone else before they take care of their own health. And that could be for many, many different factors. I mean, financial resources can be one of them, lack of access to healthcare can be another factor for why, you know, women tend not to care much about their health first. And then again, you know, language barrier, which is one of the things I kind of spoke about before we went on air. You know, language barrier, it continues to grow in the United States in regards to being able to provide, receive care, healthcare from a provider who knows the language, knows the culture, and is able to relate to the patient, and we find a lot of times where physicians aren't relating to the patients, and not only in the exam room, but even from, you know, entering at the door. They don't look like me, they don't speak like me, therefore I come in one time and never again. Or I find my diagnosis and I have someone who speaks Spanish or other languages beyond English, and then from there on, who do I go to? Where are my resources? Who can I confide in to be able to receive these services? So those are also some of the factors that can put a Latina more at risk to contract HIV.
Okay. Thank you. All right, and so Heather and Sandra have both sort of given us a frame or a snapshot of some of the things that are linked to African American women and then Latino women. And so, Jillian, if you could follow up and talk to us about, as a community coordinator, what are you finding that your clients need? And what are some of the obstacles that you face when working to help them meet these needs?
So a lot of our clients that we serve at their REACH clinic through UPMC, we do see, again, just to piggyback off of what Heather and Sandra already touched on, is that their basic needs are not being met. So we're talking about housing insecurities, we're talking about food insecurities, those barriers for medical care, which make clients, they, you know, need help navigating the systems when it comes to substance abuse treatment, mental health treatment, things to that nature. So previous to me being a community coordinator, I was the housing coordinator. And again, like housing, trying to find secure housing, trying to find stable housing, trying to find safe housing is like one of the biggest barriers for the women that we do serve at our center. And we do try to follow that housing first model. We want to make sure that our clients are housed safely so that they can adhere to their medical and their medication treatment. So those are some of the things that I do see in my role, is just making those connections, helping these people navigate. I know that it's difficult for the average person sometimes to navigate resources. So just imagine having this diagnosis on top of other social economical barriers and other maybe trauma. Maybe you're dealing with trauma and substance abuse treatment, and then you have to put the HIV diagnosis on top of it as well. So, just helping their clients to navigate through the system and follow up has always been difficult. But, as you said, we've all been working in this system for a long time, and you find ways to work with the client and meet them where they are and just try to help them to follow through with certain things that maybe they have difficulty, doing on their own in regard to housing, substance abuse treatment, and mental health treatment.
Thank you so much. You all are just bringing up so many wonderful points and so much information that I think that in many cases, it seems that we haven't been discussing in a consistent way in these broader platforms. And so I know, at least, as it relates to my role with the YWCA, I most certainly appreciate all of you being here tonight and for sharing your levels of expertise. And so some of the other questions that I'd like to get into, when we think about where we are right now in society and what's going on in our current, just in society in general, what impact has COVID had on clients to obtain treatment or to, maintain adherence and those different things? And this is for, whoever wants to jump in and take this one first.
I'll jump in. I think, overall, we had a discussion earlier in regards to how COVID it's not very different from HIV when it was really out and spoken about. The risk factors, even though they're not similar, but, the trend on how individuals get exposed is similar. So individuals are really, I think, with the patients that we work with at SAGA and in the community we work and serve is the fear of being able to go to their primary care physician and get the help and the services they need. So we know that there's a lot of individuals that are, they're taking the universal precautions and they're following the CDC guidelines to make sure that they're, using their masks, that they're washing their hands, that they're just taking those universal precautions to protect themselves, understanding that their immune system is already compromised. And COVID, puts a hinder even more on the immune system of the individual who's positive. So, in a way, it has impacted the community with HIV and AIDS and overall, of course. But when we're talking about patient Latinas, already they are concerned about their family, the health of their family, and stepping into a care provider or a hospital, it's fear. Many individuals are feeling the fear of, if I go there, then I maybe get infected, and then with COVID, then I'm bringing them home and I'm taking care of my children. Like, I'm the primary provider for my family. I'm cooking, cleaning, doing the schooling now. As we know, a lot of the parents are doing this new teaching mode that they may not be used to do or have done ever in the past. So I think it has definitely impacted the patients. But the most important thing we try to make our Latinas aware and overall all of our patients is that, the hospitals, the clinics are taking also the universal precautions to make sure that it's safe for all of our patients to go to their medical provider. So we need to continue to encourage our patients to go to their medical provider to attend their appointments. And if they do feel uncomfortable, there's also virtual health plan platform that they can utilize so that they can see their doctors and still get the care. And ultimately, the other factor is adhering to their medication. When it comes to COVID, it does impact you. It doesn't have any vaccination now, pretty much barely any treatment that can be given to the patient. But if the patient with HIV/AIDS continues to take their medication and maintain a strong immune system and are adhering, then that actually puts them even on a better place to be able to fight against this virus that's coming into their body if it was to come in. So I think it's important that we continue that awareness and continue that education to our patients, not to gear away from taking their medication or seeing their primary care physicians.
I'd like to also follow up after Sandra. Like she was saying, the population that we work with, individuals are already immunocompromised. So you're thinking about individuals who have comorbidities. They may have HIV as well as diabetes, high blood pressure, asthma, other respiratory issues. So the thought of them contracting COVID-19 really, really puts the population in a vulnerable place. So I have seen a shift, mainly with like age 25 to like 40, where if we're talking specifically about women living with HIV, in regards to COVID-19, they're the ones still going out. They have to work. Most of them are essential, whether it's grocery store, the hospitality industry, healthcare, whatever, you name it. They're face to face with people who may have COVID, and they're really worried about bringing it home to their parents. Or they're on the other end of the spectrum where they're at home teaching kids, taking care of older family members. And with that, I've seen a lot of isolation and a lot of emotional and mental health being experienced by HIV patients. And it kind of gives you an upswing because I've also seen and heard and witnessed a lot of those individuals reaching out and taking their mental health seriously. So enrolling in therapy or telehealth or telemedicine, mental health sessions, things like that, just to help them get through COVID. And so I think it's definitely not a good place to be in when you're already dealing with a lifelong illness. But for you to have to experience a pandemic on top of another endemic, I think people are trying to do the best they can. But I think this unfortunate circumstance has really created an opening for people to address their emotional health and their mental health while they're trying to deal with COVID.
All right, so kind of moving along, but linked to much of what you all have talked about. Much of what we talked about are for folks who seemingly have been diagnosed. And so talk a little bit about what is happening to increase the prevention of the spread of HIV in our communities, and again, specifically as it is addressing women.
At our program, at REACH program, we have recently started a CQI program where we're working with the women in our clinic who have shown a history of increased viral load. So what we did in the beginning, and actually we did it before COVID, it just kind of was really helpful that we got started on a lot of new projects prior to COVID to help out. We did a survey with the women to try to identify what their barriers to care were, what their barriers to taking their medication were, and we were able to collect the data and then figure out and build a program where we can do a peer-to-peer program for the women in our clinic. So what would happen is we would have other women volunteer that are already have been diagnosed and are kind of veterans per se, and have been diagnosed for maybe over 10 years, and they could link with other women in the clinic to help them take their medications, do check-ins, do virtual meetups because we can't do physical meetups at the time, but the end goal was the physical meetups. And so we have been working diligently to build that program. And we've had a lot of, turn-ups and things turned all around because of COVID. But I'm very confident that it would be a great program, just like Heather talked about with dealing with a lot of the mental illness and lock-in and isolation, things that a lot of our women are already dealing with. This program will be just a wonderful program in general to help these women understand it and know that they're not by themselves, that we care about them, we care about their well-being, and we care about their mental health. So that is one of the things that we have been working on recently with at the REACH Clinic in regard to, outreach and bringing women in and trying to get them very active within their medical treatment.
Another area that we sometimes hear about, I'm sorry, Sandra, did you want to respond to that one as well?
Yeah, I did. Actually.
Sure, go ahead, go for it.
one of the things that we are also doing in SACA is, I'm not sure how many people are aware who are on this webinar and familiar with our organization, but we have a Spanish radio station, 91.3 FM out of Lancaster and 100.3 FM out of York, Pennsylvania. And one of the things we try to do as much as possible is continue to educate our community overall, definitely our Latino population and African American, but overall all women and men about HIV/AIDS awareness and prevention and treatment and access. So we use our media wave to be able to do that. One of the other things that we continue to do is even like Jillian said, before and after or during the COVID currently, we still run our support group. So we have a support group for people living with HIV and AIDS, and we try to make sure that we partner them up with mentors and individuals who can provide them that support that they need on a daily basis, or someone who they can lean to or call when they feel lonely or isolated. So those are the things that we continue to do, and we embrace that because we know that, you know, in these tough times, our clients need our help, and even though certain institutions close down or are not open or functioning at a normal operation, we know that they need us, and we're here for them, and we continue to provide the support group for them as well.
And so then talk to me a little bit, or all of us a little bit, about why is it important for women to know about PrEP and PEP?
I can go on this one, I'd say. It's important for women to know about it. Well, firstly, PrEP would be the prophylactic. So normally people who have partners who are positive and they are negative, they take PrEP. So it could be Truvada, it could be a lot of other medications, but they take that to give themselves a better shield in not contracting HIV. So I would say it does definitely work, but things only work when you work them. So if it's a woman interested in taking PrEP or PEP, it would be beneficial if she knows her diagnosis early on to know if she's negative. So PrEP and PEP really work significantly when one person is negative. It's not suggested that a person be on it and they're already positive. That's just not how it works. But I would say it's more beneficial for women if they're interested in that, because it saves them in the long run. If they are continuing to have a partnership with someone who's positive, or if they may or may not have multiple sex partners and they want to just stay safe. It's always an option. And then also too, you have the pre and you have the post. The post is more or less if you think you've been exposed to HIV, you know, if you've had unprotected sex with someone and you're not really sure, but you may be a little bit too early to test, since HIV normally shows up between about 1 to 8 weeks after contraction. You can take the post. But back to it just being a beneficial option for women, both African American and Hispanic women, you may not know what your partner is bringing home, which really, really hits home where we all spoke about in the beginning about the men having sex with men who then bring it home and have sex with their partners who are female. So I think it's really beneficial that people are aware. Not a lot of people know that PEP and PrEP are for people who are not HIV positive. I know that commercials are out now, you know, Biktarvy, Truvada, other antiretroviral commercials are out, but not a lot of people who aren't in the HIV community know what it is. So I would say if someone is negative, if it's an African American woman and she's negative and she's at the doctor just getting tested for HIV, that may be a question you want to bring up to your provider, just so that you can get resources and a better understanding of what the medication can do for you.
And Keisha, also to piggyback off of that, I did forget to mention that REACH, we have a new program, a new PrEP and PEP program, and we are specifically targeting communities with women, with communities who have women of color, and also MSM as well. And we have been serving some clients in the clinic, and starting January 1, we will be able to cover people who are uninsured as well. And we are the first clinic in the area that is going to have that ability to do so. So yes, I just wanted to add that to in regard to what programming is available for women of color in the community. And I see a question. It says, what is MSN?
That's what I was going to say. If someone could elaborate on that.
Yeah,
on that.
we say MSM or men who have sex with men, or the same gender loving. Same gender loving. Yeah.
Excellent. And that actually transitions into what I was going to ask next about insurance. Like when you just talked about, Heather introduced and talking about PrEP versus PEP, and then Jillian just talked about some of the things that, that the REACH program is offering. Is it common to have these sorts of programs and outlets and assurances for folks who are uninsured and underinsured?
Yeah, sure. I can start. Or no, Jillian, you can go if you want.
Sure. Yeah, I'm sorry. I was looking at what somebody was commenting over here, but it says something about our information. So yeah, it's not common in this area. And like I said, it is, we are the first clinic to offer it to people who are underinsured in this area. PrEP and PEP are very expensive. And most time the people that we serve about 50% of people who are African-American in our clinic. A lot of those people do not have insurance or can't afford the PrEP or PEP services. So it's not something common in this area, I would say. Heather could probably speak to things nationally. So we are very excited to be able to offer this to the community.
Yeah, not necessarily nationally. I'm not too well versed on insurance all over, but like Jillian said, it's not likely in this area, but there are programs nationally called ADAP, but in this area, it's called the Special Pharmaceuticals Benefits Program, and they do cover medications if you qualify. And two of the qualifiers are you have to either one, be HIV positive, or two, have schizophrenia. And so if you meet that criteria, and there are income limits and that it is an insurance program through the state of Pennsylvania that will cover your medication. So there are clinics that are great with that, like REACH. I think Hamilton helps out with uninsured and underinsured. Also, SACA. I'm not sure how far they go, but a lot of the programs that we have in the greater Harrisburg, York, and Lancaster area, they will utilize Ryan White funds to also help people cover PrEP and PEP medications.
Agree. And some programs such as SACA, we do have a 340B pharmacy program. So through our 340B funds, we also can help patients and clients who may need the assistance for the PrEP and PEP. And just for our viewers, just to kind of add a little bit more, I'm not sure if Heather touched base since my connection kind of went down a little bit, but one of the things I wanted to mention about this is the follow-up. PrEP and PEP does need a doctor or provider follow-up often. So it's important that the individual, I'm sure when they discuss this with their primary care physician, that they will definitely inform them about this. But there are follow-ups that the patient should be making with their physician or their provider to be able to get the medication and the blood work and things like that follow through with that.
Normally, I would just continue down my list of questions and then we jump to some of the ones in the chat a little bit later, but I've been trying to keep up with all of you and see how things are popping up in there at the same time. And there are a few questions and comments in here that I think relate to some of the things that you all are, have recently talked about or currently talking about. So I want to address some of those and then we can kind of go back and forth between what we have and what's here. And so the one person, Dr. Hamlin asks, is there universal coverage of HAART, which is highly active antiretroviral therapy? And I think if I'm understanding correctly, I'm not going to say what I think the answer is based on what you all have been saying, but I did want to put that out there because I think that question falls directly in line with what we're talking about. And then I'll go ahead and address some of the other ones in here as well.
Well, the short answer to that is yes. So the HAART and ART and everything in the realm of antiretroviral medication is covered under a national program called ADAP. And that's like the umbrella for pharmaceuticals for individuals who are HIV positive, who may not meet the other requirements for Medicaid or private insurance. So it will cover that, although it's broken down into state, like I said before. Pennsylvania's is called SPBP. Another states may be called something, but it's all under that ADAP umbrella and it will cover that medication. And
then something else that you all mentioned when you were talking about PEP and PrEP initially I got like really excited, like, oh, this sounds like such an awesome preventative opportunity. But then shortly thereafter, he talked about how expensive it is and how, many folks then would not be able to necessarily afford it. And so one of the other questions in here links to that. Sorry, my screen just went down. Oh man. And the question is basically about awareness linked to PEP and PrEP. And so how do you get the information out there to folks that this is available and what the value is?
I know there's a lot of different testing sites. Lancaster, York, Dauphin County have testing sites, and predominantly a lot of them in the many testing sites, they do have information. Reaching out to the Pennsylvania Department of Health, they can also obtain additional information and resources that they need on PrEP and PEP. If they feel that they've been at risk or they are in a relationship that most likely put them at risk, they don't necessarily have to see a physician specialized in HIV, but it's more conducive for them if they do. But they can even have some type of discussion with their primary care physician and make them aware as to what their risk factors are. And sometimes they even provide these screenings of STIs and HIV in their primary care with their primary care physician. So even having that start up the conversation can help them to be aware as a physician, and then also to be able to have that information for their patients, because there might be other patients that they're providing services to that may not have had that conversation about PrEP or PEP. So there's many different resources and way that individuals can obtain that information, but most definitely many Ryan White providers in the area provide these services. Pennsylvania Department of Health, there's just many different resources that are available in the community. It's just a matter of individuals accessing or calling to obtain that information.
And through testing as well on our site, we have recently also added that in our counseling piece for testing, is to let the individuals know that we do offer PrEP and PEP services. And that, we make sure that our clients that are HIV positive are insured. But again, like reaching those people are the 5% of people that are not uninsured and can't access PrEP or PEP on their own, that we do offer those services. So it's just a conversation and ramping up like marketing and across the system, across the UPMC healthcare system is also going to be our plan to do so we can start getting the word out.
I agree with Jillian. Like when testing happens, your provider can definitely disclose information about PrEP and PEP. Also, just from some things that I've seen previously, when a patient would come in who's already HIV positive, they would also bring their partner in and say, hey, this is my partner. We are, married or we're whatever. But they are interested in getting on PrEP and PEP, and we would like to talk about it. And then the provider, would let them know what options that they have together or separately. But it is something that can be discussed. And I think it should be discussed at any time when you're talking to a patient and they disclose that they may be having sex with multiple partners or one partner, but they have a primary person that they're with who is HIV negative, just for protection of that other person.
I know that some of what you all talked about, you used some things that were linked to mental health. We talked about it a little bit as it was linked to COVID and just in some of the answers in general. And so one of the other questions is there automatic mental health referral after someone is diagnosed? And then is there any standard follow-up, knowing that, being lost to care after diagnosis is so detrimental to long-term outcomes? Any thoughts?
We typically offer mental health referral after the client has done an intake and have seen a provider. We'll go in and try to figure out what are some of the needs of the client. If there's substance abuse treatment, if it's mental health referral that they need, if it's housing referrals that they need, we try to do that assessment after their first intake. There's not an automatic referral to mental health because not everybody needs that. I've met with clients over the years who are, they've come to terms with their status, their diagnosis, And, you know, we try to stay connected to them closely after their diagnosis. We do check-ins, we call. Some of the clients will give them our number. They will call us every day sometimes if they need so. But not always is there like a automatic mental health referral needed. So also, you think sometimes some of the people that we serve live this lifestyle, and some of them are aware of the, you know, the risk that they take when they have maybe multiple partners, or things to that nature, or if they're IV drug users, as Sandra had explained before. So some of them may be expecting a positive diagnosis. So again, like, you know, I mostly have seen that when we have a woman come in whose partner infected her and she had no idea. Yes, the emotions are high, mental health is everywhere. I think that would be for any of us. But again, it's kind of making the client make that decision for themselves. We don't automatically make the decision for the client.
Yeah, I agree. And with SACA, we also internally have a mental health program as well as a drug and alcohol program, and we pretty much assess the patient where they're at when they're with their diagnosis. Kind of what Jillian said, we take all those factors into consideration, whether or not the individual needs a referral, and ultimately we really come to think about, you know, many of our patients are not ready to go see any mental health provider. You know, especially in the Latino population and in women, you know, you're telling me that I'm crazy, and that's why I need to see a provider. And that's, you know, and that's not accurate. We know that there's depression, there's anxiety that pops up when someone is newly diagnosed, especially if they were not expecting it. Now, they're expecting that because of the risk factors, then not necessarily all the time, but sometimes, most of the times, people already know it's expected. Okay, let's get on what's next. Some individuals, what we try to do also is at the time of counseling and testing, it's when we also kind of assess that and whether or not that patient, you know, that came in to get tested, you know, brought them in. And if they're already going through that anxiety or that stress or the fear of being HIV positive and whatnot, and they really are not coping even with the actual test, then we try to make sure that we provide the patient with that information, that it is available. And even if patients who are uninsured or underinsured, we also have resources within our organization to be able to provide that service to them at no cost or real reduced cost.
And so there's another question. Uh-oh, am I still there? I'm sorry, all of these other screens just jumped up. There's another question linked to mental health, but this one is from the perspective, or looking at it from the perspective of a person who has some different diagnosed mental health related conditions, and then they are diagnosed with HIV. Yeah, they're diagnosed as HIV positive. Are there any methods, and Sandra, I might toss this to you initially because you did mention that SACA has all of these different elements under the same umbrella, but are there any things in place to help that person remain consistent with both sets of medications?
Absolutely. You know, we tell the patient that most definitely you never want to stop taking your HIV medication. And that's something that a provider, a physician will take into consideration when they're providing or prescribing any heart or ART medication to patients who are HIV positive. So, you know, we want to make sure that they continue to take their medication just as education, and we try to provide across the board for all of our staff to ensure that all mental health providers and individuals, therapists are taking the training to ensure that they continue to provide that support that that patient needs. And it's ultimately to the patient of whether or not they want to disclose that to their therapist or their psychiatrist. So it's not information that we, even though we have everything under the same umbrella, that we just disclose to other colleagues and within our organization, because we want to make sure that we protect the patient confidentiality, and that they are willing to allow us to be able to provide that information. So they do sign that consent, and we definitely kind of discuss, you know, even though we already had been in conversation for their care plan moving forward, we try to make sure that we can link them and that they continue to take both medications until the physician has said otherwise. So that's normally what we do, and under our same umbrella, you know, we try to make sure that even if we have patients who are taking Suboxone for drugs. So, you know, we try to make sure that the patient is aware that they shouldn't stop any medication without consulting the physician first. And if the physician determines one way or another, then it's up to the patient and the physician to determine that.
Anyone else like to chime in on that one? All right, and so you wrapped up in saying that you want to make sure that they talk to their physician, before they potentially stop taking anything or there's any changes made. We also talked a little bit about how you've had to change the way that you are able to engage with some of your clients and different things because of COVID. But do any of you have any information about how doctors perhaps have had to shift the way that they're meeting with or engaging with the patients during the age of COVID, particularly with the numbers going back up?
Well, I think Heather alluded to that earlier in regards to telehealth and telemedicine. Those are some of the shifts that many doctors and clinics are doing to make sure that they continue to impact and help our patients throughout this pandemic. One of the things also, actually, when I'm feedback to what I was talking earlier about mental health, is also the medical case managers. We have medical case managers that work diligently day in, day out with our patients to make sure that they can navigate the entire system as long as they allow us to help them. So, that's another way that we try to make sure that we're helping our patient in the entire transition. And even with COVID, we try to make sure that we provide the access. Can't all assume that all human beings have a smartphone and they're able to access telehealth, like, by click of a finger or whatnot. So we try to make sure that if a patient needs any technology to be able to access and have that telehealth visit with their physician, that we're providing those particular technologies so that they're able to do that as well.
I would agree as well, Sandra. We have done a lot in regard to telemedicine and working over the phone. Again, just like you said, like medical case managers have been angels in disguise, especially ours, with, check-ins, daily check-ins with our clients, weekly check-ins with our clients, ensuring that they have the things that they need in regard to the medical care and also that support the social side of things. So we've even done Instacart for moms who have had to stay home with their kids for school to make sure that they have, food in the house and everything in regards to housing, security, like housing, utilities, food. We have found ways to get around this COVID thing and make sure that our clients stay connected to care, because if we haven't learned that through this webinar, we have learned that women taking their medication, all HIV positive people, but taking your medication is number one, and staying safe. And I don't know if a lot of people are familiar with U equals U, but that's another very strong component of our program. We like to educate the community on what U equals U is in regard to stigma as well. And that is, if a person is undetectable, if their viral load is undetected, it's less likely that they will pass the virus on to their partner or to other people. So these are all just components to keeping people connected to care, making sure that their viral load is low and that they're taking their medication.
We have another question where someone's following up. Sometimes when we use terms, our audience might not necessarily be as familiar with some of the jargon. What does ARTAS stand for? I think someone mentioned this, ARTAS.
So I can't right now from the top of my my head tell you what ARTAS actually stands for. But I can describe it to the individuals. That's what ARTAS is.
And
ARTAS,
I see it looks like Adam's going in and layering
thanks,
the
Adam.
details as well.
Yeah, ARTAS is actually an evidence-based intervention that the CDC and the Pennsylvania Department of Health had instated into being able to link individuals who were newly diagnosed. It's a session-based, evidence-based intervention. And this particular ARTAS is utilized for people who are newly diagnosed, who are still like pre-contemplation, really not knowing, do I want to move forward with treatment? Do I want to move forward with care? What do I want? What do I do? And what we try to do is, once a patient is newly diagnosed, they're referred to some type of case manager who will pretty much work different sessions with this individual to get them to understand what the virus is, how to get the help that they need, getting into treatment, what barriers exist for them to get to treatment and maintaining and linked into care. So those are kind of the steps that takes for a person who basically a program who has artists. So there's limited programs or agencies in the state of Pennsylvania who provide artists, but we're moving, the Pennsylvania Department of Health and CDC is moving a little bit more towards providing artist programs and training to the different facilities and providers to be able to have more of a warm handoff from patients who are newly diagnosed to, for example, it could be REACH, it could be Lancaster General Hospital. So those are organizations that predominantly occurs in the medical field setting, but if not, organizations such as SACA can also provide artists and be able to be that linked to find the support for that patient.
And so let's shift gears and talk a little bit about messaging. As we were, started chatting as the webinar was getting ready to begin, we talked about how, many years ago, you couldn't turn a channel without seeing something linked to HIV or AIDS awareness. You couldn't see, there were campaigns, there was literature, there was information, it was everywhere. And while you all are doing amazing work, and as I was preparing for the introduction for this, I found all sorts of wonderful things that are happening in this area. We don't see it in the public setting with as much intensity as we did in the past. Any thoughts on what's going on there, or why that's the case?
I think a lot of it still resides in stigma. A lot of people still feel that it's a very taboo thing to discuss and talk about, even though it's been here, since the late 70s, early 80s. Research is still going on for a cure, for something to just totally wipe out HIV and AIDS altogether. But I think a reason why a lot of people don't discuss it and the messaging isn't as pervasive as we would like is because for particular age groups, they just think that HIV is not important, like it has disappeared. And although we do have antiretroviral medication that has really suppressed individuals' viral load and increased their CD4 count, giving them a better quality of life, it is still very much alive. We still have new cases every day by the thousands every year. And HIV is definitely something that needs to be brought back to the focal point. Obviously, we're in the middle of a global pandemic, but it's still something that needs promotion. It needs marketing, PrEP and PEP needs marketing, treatment and prevention, especially in low-income rural areas where they may not have that much access to technology and or medical services, because people in those counties that we wouldn't even imagine, they are contracting it either by intravenous drug use or having sex with individuals, and they may be unaware of their status also. So I think the messaging and programming behind HIV may need a bigger push in the coming years, just to let people know that this is still out here. This is still something that you can get, and it is a lifelong thing that you live with. And we do have medical advances that have really catered to HIV to make one be able to live and do anything else, just like someone living with diabetes or a cancer survivor. HIV is not a death sentence anymore, how it was in the early and mid 80s. However, we do want to let people know that it is a very serious thing.
I agree with that, and I just want to piggyback what Heather said. It's pretty much very prevalent and present, though kind of what Heather mentioned, the fact that there's medication, many people think, well, if I get HIV, I have a medication, now I'm living longer, so I don't care. There's populations that actually want to get infected. They're part of these different social media chat rooms, and they're getting infected just so that that's one less thing I need to think of. I already know I just take a medication and I'm moving forward. So those are things that are happening as well. The other thing that I'm seeing, and specifically because it's hard and dear to me, is the lack of education and awareness that continues to occur in the school sector. Now in the schools, the education is not being or informed of HIV and STD as much now as it was before. You know, they have other priorities that they need to think about, and I understand that when it comes to the education and in the schools. But it's very important that we continue, you know, as parents, as advocates, as providers and people from our community, that we continue to be part of that discussion at the school boards, and making sure that the school board understand that this is very prevalent. It's very much in our community, in our back door. And if we don't continue to increase this education at a young age, then these numbers are going to continue to increase as these youngsters continue to grow and be more sexually active. So it's very important that we also incorporate, you know, the educational part of this, and making sure that our kiddos, if we're not doing it at home, providing that education, that at least they're receiving it in some other format.
I agree, Sandra. A lot of it, prevention is so important. We recently opened a recreational center for MSM and transgender women of color in the we call it the GLOW program, but it was formerly Project Silk, which is in Philadelphia and also in the Pittsburgh areas. And education is a big focal point for GLOW. We are targeting that population, also the ages between 14 to 29 of that population, to come in and get educated. And we are getting, we have been able to engage children in that age group to talk about HIV freely, and to learn from people who are already HIV positive. We have testing on site, STD and HIV testing on site. They have all type of programming, not just related to HIV, but just creating that safe space where these young children can come and talk about these things, and they can know what to look for rather than trying to figure it out on their own. Back when I started almost 11 years ago, HIV prevention was a big thing. It was groups of us would go out to the community. We would hand out condoms. We would talk about HIV within the schools. And I've just noticed that over the years, it's just diminished to nothing. And I just think that if people are in charge of programming in relation to HIV, that prevention, we get back to focusing on prevention and education for the age groups and the populations that are most affected by HIV.
I agree with both Sandra and Jilly, and it's something that needs to be not grazed over in health and sexual health classes in high school or even in middle school, just depending on, the population that you're talking to. But that age group, 14 to 29, that falls in with the second largest age group to contract HIV, which is important because if you think about a high school student, they may be sexually active and they may not know all of the intricacies of contracting HIV through seminal fluid, vaginal fluid, oral sex, anal sex. They may just think, oh, I can do this particular thing and I won't get it, not knowing that it's a very detailed situation and you need to know all of the avenues in which you could possibly end up being HIV positive just from lack of education. So it's really important to have that incorporated into some type of education for that age group, 14 to 25, high school age students. I think it's really beneficial. They have that information available.
Many of the things that you all said in this round, as it relates to prevention efforts, to educating, to getting the word out, to increasing awareness, speaks to what many of the organizations that some of us might be a part of or that just exist in our community. And so when we even look at the co-sponsors of tonight's event, like Sigma Gamma Rho sorority or the National Coalition of 100 Black Women, what are some ways that community organizations, and I'm not sure if you all know the funding streams in this area, but I figured we might as well toss this out there. What are some ways that community organizations can get funding or at least maybe partner to get involved with some of this work that goes back to some of the efforts that you all mentioned, that used to occur in various communities?
I think this particular sector, most of the grant funding definitely goes to community-based social services and medical programs. But if a community organization or sorority or fraternity, some type of affiliation like that wanted to get grant funding, they could go the 340B route, or they could also partner with a healthcare center like REACH or, Hershey Med's infectious disease department, or Hamilton or Alder or SACA, an organization that their primary population is HIV positive. I would say that's the easiest way for a community-based organization to get funding so that they could maybe work on this in a committee.
So what are
And
some,
also,
sorry about that, Sandra.
no, that's okay. I know CDC also has government funds. Most of the time you have to be a 501c3 entity, but there's also funds opportunity for CDC through CDC. For example, let's say if the school, any particular school will want to integrate certain programs of HIV and STDs or STIs within their schools, there's ability to be able to research through the CDC funds, and the school district on its own can probably do that. Of course, in collaboration with the Pennsylvania Department of Health and other sectors in that particular community. But those are other access to funds when it comes to that. And of course, private sectors. I mean, why not reach out to the private sectors in your area who has the passion for your mission and vision for your organization and what your project may be. And you can definitely kind of do it through the private sectors who is able to facilitate that fund and willing to help you in that endeavor.
And I think that answer sort of leads into what I was going to ask in this next question. This is more on the individual level of what folks can do. And so what action steps can we take to advocate for HIV and individuals in order to make real change? So is there anything else that you all would like to add, on top of some of the things that you just shared?
I would just offer that people become educated on HIV and AIDS and what it's like living with living experiences, with lived experiences. So, they're all of us are a part of organizations that have probably have prevention sectors, and somebody can come in and do trainings or education for your staff so that your staff and the people at your organization know how to deal with people who are living with HIV and AIDS. I think that's most important. Even when we talk about pronouns, she, her pronouns and different things of that nature, we want to make sure that we're educated before going into this population, because it's already a very sensitive topic. And you just don't want to offend people, so have one of us come in and do some type of education so that everybody has like a better understanding of the population that they're dealing with.
And again, stigma exists, so as an individual person, we need to provide that support to our friends and family and even to our neighbor. Kind of what Jillian said, if we're educated how HIV is spread or not, or contracted, then we're more likely to be more open to provide that support to that individual, that neighbor who needs it, or that family or friend. And I think if we're able to talk about it openly, then maybe more individuals who are infected are more likely to express their diagnosis and be able to feel comfortable among that population or that family or that network, or for them to be able to be freely and discuss what their status is and be able to receive that support. So I think, we need to increase that for sure. And especially in the Latino population, I can say, with women, besides being the individual who takes care of the family, we were taught at a very young age, our mothers and grandmothers was saying, all your dirty laundry, you talk about it at home or take care of it at home, so we're not talking outside of our four walls out about this. So, if you did it, then you deal with it. But no, I think it's important for us to provide that support and kind of bring down those silos and that stigma that continues to occur, so many years later, almost 40 years later.
Yeah, I agree with both Jillian.
Sorry.
Coming open and just being vulnerable enough and vigilant in your own care, like on an individual level, it's good to encourage people to be open about it. And again, just like in the Hispanic community and the African American community, we are not to talk about these type of things, especially with friends and family, more particularly not with people outside of the home. And that's really kind of how we get caught up, because we may have someone who contracted it and then they have a partner who doesn't know. And so it's really good to ask questions, be open. If you're a parent and you have a teenage, kid, be open with them, talk about the dangers of contracting HIV, the dangers of STIs and STDs also. But I think being open and willing to just better understand things. So the awareness and the education piece is really important. Even if, don't use it like a scare tactic, but even if you're talking to other individuals who may not be well versed in HIV and they're older than you, or, you have a respect level for them and that's not something that they're comfortable talking about, you could still express how important it is, just because they may know someone. Oh, I have an uncle who passed away from HIV, but we didn't know till after he died. We hear that a lot, in family and in our community. So it's really important to stay open, because this information needs to be spread around just so that people can stay safe and keep themselves and others healthy.
I wanted to add, not that this is from, an expert or, folks working in the field, but I think about things that, and it kind of goes with that conversation of what we talk about in the house or what we don't talk about, right? Is what I wasn't told about my body and what wasn't encouraged to discuss, right? And I sometimes, with my younger cousins or with younger women that I'm around, talking about, what do you know about your body? What do you know about yourself and how your body is, right? How we give our body is also part of who we are, right? And so sometimes I think people don't have a sense of self, or we've lost giving our young women a sense of self. And not saying that's what leads to it, but how are we telling people to protect their bodies? What are we not talking about that we think is not appropriate to talk to our young girls about, that's important to when they're going out into a world that is throwing them things left, right, and center? We're not talking about it at home, but they're going to face it when they go to school. And, they run up against these things and they don't know, right? So what are we doing about our bodies? What are we talking about with our young women? And what aren't we talking about? And not just young women, but any young person, right? What are we leaving off the table, and how do we start talking about this at our home tables?
And something else that was included in the chat, again, Dr. Hamlin included some good information and just some practical things that we can also do. And in it, she mentioned that we have to, normalize using condoms, make them available, encourage people to use them and to use them consistently. And so that, is something that's very practical, but that, for quite some time, we still have people struggling with doing that and doing that in a consistent way. So another direction that I wanted us to be able to take this conversation links with cultural competence. And much of what you all have talked about this evening most certainly provides us with some examples of how all of you are culturally competent in your work. But share with our viewers a bit about the role of cultural competence and how important that is to, like compliance or to preventative measures or to, being effective in any way.
I can go. Sure. I didn't want to interrupt. I didn't know if someone was.
Go for it. I know I should have called on someone first. Go ahead, Heather.
Competency. Just speaking from what I'm seeing at the Pennsylvania Department of Health, we kind of just look at the barriers that people are facing culturally, and that can break down. If we're talking about the African American community, that can talk about small regions that have communities of Nigerian families or Jamaican families, Caribbean families. Other different groups of the diaspora that may have their own challenges when it comes to health care, health equity, and access to care. And those language barriers and cultural ones, if someone's from the Caribbean, they might not even go to the doctor just because of the stigma. Or we all know, especially as of late, just the inadequate service and treatment that African American women receive when they go to medical establishments, as far as pain medication and the perception of Black women being able to tolerate a higher level of pain. All of these different treatment avenues that we kind of have to go through just to get the basic level of care. A lot of that definitely stops African American women, be it from any community, from getting the care that they need, even if they are living with HIV, especially if you are in a community that really cherishes marriage. And let's say the husband is secretly sleeping with a man and he brings HIV home to his wife. A community or a particular culture may encourage the wife not to leave the husband. And then that wife has to be stuck there, and then she's kind of ashamed. She may not want to be seen at a hospital. And so you have people who are living all of these different lives kind of hidden away, not being able to get access to care. And that also goes with language barrier. If someone speaks Haitian French or Creole, or, they could be from an African community in another state or something like that. It really is something to think about. And I know a lot of people don't think about it. They think cultural competency and they just think, don't be racist. And that's really the baseline of it all. Cultural competency comes into play, like what Jillian was saying, getting people's pronouns right. If you're working with a particular population, let's say for transgender women or trans men, there's a different language. There's a whole different alphabet of things that need to be said and addressed so that that patient can feel comfortable. Or cultural competency to someone who may be of a different religion, and you may use mannerisms with your hands or your body posture that could offend them, and now they're no longer coming back to get care. So cultural competency is a total wraparound package when it comes to HIV, and I don't think it's addressed enough.
I agree with everything Heather said when it comes to the Latino population. I mean, it mirrors completely of the reason for why women of color and Latinas do or do not obtain the services. Another thing that plays a part is the machismo when it comes to the Latino population. It's sad to say that, but it's so honestly the truth, and individuals may not go into care because of that. But it's important, as I mentioned earlier in our conversation, is that when we are incorporating cultural, and especially for the Latino population, we definitely tend to go into any particular sector, social service providers, doctors, anywhere. And even sometimes even going to just a specific store, we want to look for someone who looks like me, who speaks to me, who, if I have a question, who can answer that, who can relate to me. And even within the Latino population, a lot of individual things that Latinos are Puerto Riqueño or Mexicano. And we're not all Puerto Riqueño or Mexicano. We have also a huge umbrella under us as Latinos or Latinas as to the different individuals and also their dialects. There are many different wordings that a Puerto Rican may use that is not the same, and it doesn't mean the same, and it doesn't translate the same as a Mexican or Salvadorian or a Venezuelan person. So it's very important that when we're in the hiring process, if you have that capacity and you're in the hiring process, to make sure that you keep that in the forefront and think about, hiring individuals who look and represent, but also culturally can embrace the community that you work with, and understand that you have a little bit of everyone in your organization that can provide that service, and everyone across the board can also get that training, but not necessarily only the training to get to know a little bit more about that particular culture that you're serving, but represent that culture.
Excellent. Thank you all so much. Much of what you all talked about then led me to think about gender as a social determinant of health. And so, as you all were mentioning, there are so many things that we look at that fall under like being culturally competent, and how different cultural norms come into play. But even when we talk about gender as a social determinant of health, even if we look at these binaries, say of man and woman, again, as we've talked tonight, we know that there are all sorts of folks that don't fit either of those binaries. But even for those that do, the way that that woman is defined in certain cultural spaces, or the way that man is defined in certain cultural spaces, most certainly then does impact health and health outcomes as well. There was an article that I was reading that came to mind as you all were talking, and it says that the title of it is "Men Die Quicker, but Women Die Sicker." And essentially what it's stating is all of the things that you all have discussed tonight, and where women are socialized to spend so much of our time taking care of everyone else, that even if you technically have a longer lifespan, your lifespan isn't necessarily healthier. And so as you all were talking, that came to mind as well. So there was another question or comment in here that I wanted to make sure that we addressed. They were popping up as you all, again, were sharing some wonderful information. And in it, the person states that, thanks for bringing up the Caribbean cultural piece. We will try all kinds of home remedies first before we'll ever think about going to the doctor. And I wanted to read that because I think that, that's common in a lot of cultural spaces. I'm a health communication professor, and I admit that there are times that I am still like, well, my grandmama said this before I want to try, some of the other things. So it's deeply embedded in who many of us are culturally. So are there any other things that you all just want to share with us and share with our audience tonight? Any things that when it's all said and done, you really want our listeners to sort of take this home, sit with this, and then use this going forward?
I did want to touch on one thing you said, Dr. Keisha. Men die quicker, but women die sicker. That's definitely something that we're kind of focusing on right now, just monitoring healthcare access. Women are 1 in 9 as far as not knowing that they have the diagnosis. So if you have 9 women, only 1 of them know that they have HIV, but all 9 have it. And if you break it down to African American women, it's 1 in 7. So if 7 women are standing next to you and they all have HIV, only 1 actually knows because they went and got tested. And what that really shows is a trend for specifically women, but men are more likely to go get tested and be upfront about, I know I did this with this person, I need to get it checked out. And where women come in kind of the short end of the stick is because, again, they may have a partner who identifies as, a man sleeping with a man, and they don't inform their female partner. So the woman goes about her life and she doesn't know, which means she gets diagnosed later. And what that means when you break it down to a clinical level is if a woman's getting diagnosed, let's say 3 years after contracting HIV, she has already had a latency period where her viral load is just going up and up and up, and her CD4 count is going down. Her body is not being able to fight off the HIV virus in her blood. And so women do die sicker from HIV because of that reason primarily. So, there are other reasons, of course, just not knowing or continuing intravenous drug use, being just kind of not careful. But the main reason why that quote is really, really true, because women normally find out later and they don't have that time to get early detection and to get the appropriate treatment.
And I wanted to add to that, one of the things that I used to talk about a lot when I did my counseling and testing years is, some women, even just for the presentation, we used to do what we called coffee chats, when we actually went into the people's home and talked to them about HIV/AIDS. Since they couldn't talk about it outside of the house, we came into their home and said, okay, so let's have this conversation in your 4 walls and help you understand the virus and everything. But one of the things we used to always say is that, a person, and especially in Latina women, if I'm married, why should I get tested? There's no reason for me to get tested. And one of the things that I tell the person is that is correct. You're married and you trust faithfully on your husband or your spouse, the loyalty and whatnot. But one of the things that I tell the women, I'm dead here before I go dead. Hold on. One of the conversations that I have with the women of all colors is that we're not with our spouse 24 hours a day, 7 days a week. So we don't know what they do when they're not with us, just like they don't know what we do when we're not with them. So the most important thing is that we take this into consideration and at least every year get yourself tested, just so that you are aware of your status. And if you're aware of your status, then you're more likely to obtain and be linked to care and receive the services that you need. But if you are in that mentality that, yes, I definitely agree that my husband is going to be faithful until we die, and he is not going to cheat on me. He's not going to bring no diseases at home and blah, 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 blah. It's not happening. This is happening. Whether it's the male, whether it's the female, they're going outside of the relationship. They're bringing diseases home. And then the individuals at home not thinking of, well, why should I get tested, or when should I get tested? So I normally just put it back on them and say, listen, you're not with them 24 hours a day, 7 days a week. Why don't you just get a routine checkup? Either do it on an anniversary date, if you can't remember when was the last time you got it done, or do it for your birthday. Give yourself that gift to be able to go to your doctor or go to any clinic if you're afraid of, confidentiality or whatnot, to get yourself tested and know your status. And at least if you know that and have that routine checkup, then you're more likely to pretty much kind of nail it down to, what was my last exposure and when did I get, if my test ever does result positive, then I know at what period of time was my exposure. But if someone who's never gotten tested and who could have been kind of, back what Heather said, been infected for 3 years and don't know that, then, their viral load could be very high. And if we're trying to suppress that, they will not be able to suppress that unless you got, well, not that they won't be able to, but the suppression takes a little longer versus if the person is not diagnosed at a very early time. So, continue to tell and encourage every woman, even if you are in a relationship, a stable relationship, you should at least get tested every year.
I would always also like to add on the back end of that for women who are single and are dating, and with so many different platforms for dating, we have like POF, all these different Facebook dating apps, all different type of apps, and it's okay to have that difficult conversation with someone that you may be considering having sex with. You can ask, it's okay to ask to see test results, or maybe go get tested together before you actually have a sexual encounter, and it's okay. And I think that as African-American women and Latinx women, that we can start to be comfortable with having that conversation. And I always say that in my education classes or trainings with people that I am married, but say if I was single, I would say our first date could be HIV. Let's go get HIV. Let's go get tested for HIV and STDs, just so we can kind of like get that off our, something, one less thing that we have to worry about. And it's an awkward conversation, but I feel like if you can't have that conversation with someone, then maybe it's not the best decision to lay down and have sex with them, because then you're putting your life on the line. So I try to encourage people, my friends, my family that I know that are single women are dating, is like, you get in that honeymoon stage and you're all in love and everything like that, but you really don't know the person that you're having sex with. So let's make it normal. Let's say do you have STD results, or do you have an HIV result, or why don't we go get tested together? It only takes a minute. We can get our test results in 1 minute, and then we don't even have to worry about that. That's one less thing that we have to worry about together. And also for women, and men too in general, and vice versa, if someone is comfortable with having sex without protection, what are they bringing to the bedroom? Let's talk about that. If somebody's so quick to just not use a condom, well, you're not worried about what I have. So I think normalizing the conversation and bringing confidence to women and say that you are worthy to have this conversation. You're worthy to go to bed with someone and not have to worry about if they're going to give you a sexually transmitted disease. So like you women said, and making it normalizing, getting tested, being tested annually. Why not be tested every 6 months? It takes a minute again to get tested and get your test results. And it's like one less thing that you have to worry about. And I think in that area of prevention, we will see our numbers decrease for women of color and Latinx women.
Well, I just want to thank everyone so much for participating tonight. All of our Community Now discussions are posted on our website. And so we ask everyone to continue to walk alongside the YWCA as we continue to push and have these essential conversations. This was a wonderful panel. I thank you on behalf of the YWCA and the team that pulls all of this together. We so appreciate all of your insight, all of your expertise. I know that I learned so much through this discussion, and I'm sure that those who are listening have learned so much as well. Thank you so much.
Thank you for having us.
Here, I think it's still recording. That's why I always just smile until Adam usually says something. There it goes. You see what Stacy just wrote.